Well, hello. Welcome to this month's iCubed. This is Dr. Alice Lee. This is episode number 14. Believe it or not, this is the second year of iCubed. I'm very proud of myself. Yay! So welcome to episode number 14, and I have a return guest, one of my favorites, Dr. Elizabeth Ottney. Welcome back.
Thank you, Alice.
So Elizabeth, why don't you just briefly introduce yourself?
I am Elizabeth Ottney. I work at Banner Baywood Medical Center in Mesa, Arizona, a suburb of Phoenix, Arizona, and I've been here about 9 years. And I've worked with Alice nearly that entire time.
Exactly.
Prior to that, I was serving in the U.S. Army for 6 years to repay my scholarship obligation, and that included a year in Iraq.
Wonderful.
And then prior to that was residency, and then pre-med, or medical school and pre-med, and I did attend pre-med at Arizona State University.
Yay.
So I returned home.
That's so true of so many of our colleagues. Well, thank you for your service to the country. Now, today I'm going to challenge you a little bit.
Oh, great.
Now, we're doing something different. I usually have one case, and we'll dissect the case from beginning to end. But this time, we're going to challenge Dr. Ottney with 3 cases that have the same diagnosis. So let's start with number 1, patient number 1. So this is your typical Banner Baywood patient, 82-year-old male who has a history of CHF, and he's got atrial fib, hypertension, he's got stents, and he's just had a recent pacer put in about 3 weeks before coming in. Now he comes to the ER through by ambulance with just severe, profound weakness, and he's short of breath, and then he says he has chest pain, and it just started before when he came to the hospital. The pre-hospital note, the nurse hands this to you as you're walking in the room, and it says that the patient complains of generalized weakness. The son was the one who called the ambulance. The pre-hospital vital signs you see here is a systolic of 94 over 37. His pulse is 75, and his sats are 99% on room air. His respirators are all right. So you meet this gentleman. He's laying in the gurney. I look at him and I'm like, oh boy, he looks sick. He's awake and he's talking to me. He complains of being really weak and he's short of breath. He doesn't have an appetite, doesn't want to eat. And then again, we know that he just had a pacer put in a few weeks ago, 3 weeks ago. You look at his past medical history on his chart, pretty common stuff, right?
One thing I'd like to say is that sometimes the Banner Baywood specials we get come in with no history.
Yes.
We have no prior history on them because we're travelers from another state.
That's right.
We have no old EKGs to compare to. Some of them come by private vehicle with an elderly spouse who can provide us with nothing. We don't have an EMS run sheet.
That's right.
So this case already thrills me because I have an EMS run sheet with things that were done at the scene to tell me what kind of rhythm and rate and glucose level and vital signs, and I've got an extensive medical history and medical record, and that's fantastic.
That's fantastic.
It makes my job a whole lot.
It's true. Now, he's stable enough for me to at least look through his chart so I can get some of this history. So we get the med list, and this guy, Plavix, Zocor, Carvedilol, aspirin, really common meds that the elderly have. We look at his vitals in the ED. It's 119 over 49. His heart rate is 64. Respirators are good. Saturation is fine. He, looks alert and he's answering me, but he's very, very weak. He looks just ill, to me. But otherwise, there's not a lot of other abnormal findings just by looking at him. So the ED text brings you the EKG before anything else is done, and this is what you see. We don't have labs, we don't have x-rays, we don't have anything. They give you this, they hand you this EKG, he just had this pacer put in. What do you think?
Well, that's an interesting EKG. It's definitely capturing. He's got pacer spikes. He's got some, some wandering baseline there, but it looks like it was technically easy enough to do this EKG.
So what would you do next?
Of course, I want him lined, labbed. I want to get a portable chest X-ray as soon as possible. Clearly, he looks weak and ill at the bedside, and so he's not going over to the radiology department. And right now, we're in the midst of our flu season. So I would certainly like to try to get a flu swab and also get a urine sample to see if maybe possibly he's uroseptic or there's some other form of infection that could be causing his symptoms.
Sure, weakness has a very, very broad differential, and you've touch on multiple ones.
Also, I would like to probably get a rectal temperature. Certainly if there's a fever present, then that gives me a different algorithm.
Sure.
I'm not so concerned about the possibility of this being a post-operative complication or an arrhythmia or something else like that. So it'd be helpful to know whether there's truly a fever or not. And certainly blood cultures if there's any thought that he could be infected.
Right. So for me, absolutely. If I'm really concerned about a real temp, it's always a rectal temp. All right, so we're going to go to patient 2, all right? This is another male. He's 75 years old. He has a history of atrial fib, but he has a history of chronic kidney disease. He's not on dialysis. He comes to the ER POV, private vehicle, from his nephrologist's office because he's very bradycardic. He had some labs drawn 3 days ago by his nephrologist just for follow-up, and then he was called to the office today and then sent to us because he was found to be really bradycardic. You go in to meet him, he says, I just feel really weak and kind of dizzy and kind of faint. So once again, with this patient, just like the other patient, the tech brings you the EKG before anything else is done. This is that EKG.
What I see here is definitely a very slow rhythm.
Yep.
Very slow rhythm. I get to see about 5 beats on the entire EKG.
Yeah.
Narrow complexes.
Yeah.
They look uniform. Not really seeing much for any consistent P waves.
Yeah, I don't see any
exactly
Ps.
Maybe 1 or 2, maybe. But it looks like a slow junctional rhythm.
Yep. Right. He has a history of atrial fib. He's got diabetes, and he's got chronic kidney disease without actually having dialysis yet. He's on Eliquis, lisinopril, metformin, and sotalol. We look at his vital signs. His blood pressure is 99/58. His heart rate's 30, which we saw on the EKG. His respiratories are 18, and Rumair's sat is fine. And if you look at him, just in general, he looked fine. He's pretty normal, except his bradycardia. So, what do you think?
Well, yes, certainly my biggest concern is that bradycardia, and he's on a beta blocker, so that's one possible cause or issue.
Right.
However, he's very symptomatic.
Yeah.
He has symptomatic bradycardia.
Right.
He's a cardiac patient. So I'd want to be at least letting cardiology know that I have this case.
So yeah, you would do your routine workup, your labs, and you get your chest x-ray and all that. All right, so patient number 3. We're going to up the ante here. This is an 81-year-old female who comes in cardiac arrest. The EMS folks were called for an ill and confused patient after being nauseous all night long. There was no vomiting. En route, though, she became bradycardic and unresponsive. When she came in to our critical care room, she was already fully paced, externally paced. We got an AccuCheck, or they got an AccuCheck pre-hospital, and it was 500. She's unresponsive. She's being fully paced, and she's not intubated. So you look at her general exam. She's heavy set. She's, like I said, unresponsive. She's got a 100% non-rebreather face mask on. The external pacer is pacing away on her, and she's got some actually spontaneous mild respirations, and then as said before, she's not responsive. We're able to quickly just grab some information from the medic. She's on metformin, enalapril, verapamil, fluoxetine, pravastatin, Xanax. She's a diabetic, she's an asthmatic, and GERD history and hypertensive history. And I hear from the medics that the daughters told them that she was fine, quote unquote fine, yesterday. So this is that monitor strip that they bring me, looking like every beat is being captured, or every pace beat is being captured. So I told them, let's shut off the pacer and see what happens. And this is the only thing I get. And unfortunately, we didn't have any other strips, so this is the only thing I see when I turn off the pacer.
When you turn off the pacer, we can see about 2 native beats in that whole strip.
Yeah.
So clearly she is pacer dependent.
Completely 100%. So we turn
it back on.
Yeah. So that's the end of the 3 cases. They're all tied together by one singular common diagnosis. We've got one gentleman who comes in who just looks crappy. He's weak. He had a pacer put in 3 weeks before. The pacer's working. Number two, we got this older gentleman also who has chronic kidney problems, but he's not on dialysis yet. And then he gets sent in because he's got this severely bradycardic rhythm, no P waves, right? And a little bit hypotensive, so he's symptomatic. Now we've got this sort of out of the blue, supposedly fine lady who now is in cardiac arrest, pre-hospital. She's bradycardic, she goes unresponsive, and they start pacing her. And all you see on the unpaced monitor strip is like one blip. What do you think?
My goodness, I didn't know I was going to be doing 3 different cases.
I told you it was challenging.
The first case was kind of interesting to me because, in my opinion, his differential had a number of ways to go.
Yeah.
You've got the infectious thing with the flu season,
Right.
and urosepsis. I mean, on the surface, he didn't look ill. And that's why it's really important when the person at the bedside can say, this guy looks sick.
That's right.
Because on paper, his vital signs were stable.
Mm-hmm.
His glucose was good. He was in an adequately paced rhythm. The other 2, however, were not quite so stable. One person potentially needed to be intubated. It was a different scenario. And the other person clearly had symptomatic bradycardia.
Sure.
So those looked cardiac in nature at the top of my list. But to pull the 3 together, all together, of course, we don't have labs back. We don't have
Right.
chest x-rays back. We don't
Right.
have all of those other findings. But certainly one thing that is on anyone's differential would be critical hyperkalemia. Particularly with the history of the one gentleman with a chronic renal failure, not yet requiring dialysis.
Yep. And the other guy had a pacer put in, which requires an angiogram.
Correct.
And this last one was just kind of out of the blue with a cardiac arrest. With each of my screencasts, I want to focus our learning because there's just so much information that's out there, and I have 2 learning focuses usually with each of my screencasts. So with this one, the very first learning focus is the diagnosis that ties all 3 together. Hyperkalemia. All 3 of these patients were severely hyperkalemic, and their critical illness was due to that severe hyperkalemia. Traditionally, it's been taught that EKG changes follow the degree of hyperkalemia. So you have the peak T's, and then you've got the widened PR intervals, and then you've got the drop P waves, and then progressing on, you will have widened QRS. Is that what you learned as you were going through school? Yeah, that's the traditional teaching, but we need to throw that out, because you can actually have VFib go from normal EKG to VFib with a severely hyper-K without any warning whatsoever. I'm referring to a article back in 2008 that was written by Lawrence Weisberg. This is in Critical Care Medicine Journal. So, quote, EKG changes may not accompany changes in the plasma potassium level. The sensitivity of the electrogram to reveal changes of hyperkalemia is quite low. Normal electrocardiograms have been seen even with extreme hyperkalemia, and the first cardiac manifestation of hyperkalemia may be ventricular fibrillation.
Alex, I actually had a case like this in medical school. I was a third-year medical student doing an ER rotation, and a gentleman came in, 40s, 50 years old, hemodialysis patient with COPD and congestive heart failure, came in with the complaint of shortness of breath, and he did appear short of breath. So, of course, that made everyone think, is this a COPD exacerbation? Is he fluid overloaded from his congestive heart failure or from his hemodialysis? Of course, he was on the monitor. His stats were okay. Everything was okay. He was a little tachycardic. Baseline EKG was normal. He remained on the monitor. And within less than 20 minutes of being in the emergency room, he coded.
Oh, yeah.
So, in those days, iStats, weren't something that you could get so quickly at the bedside.
Exactly.
And so, literally, we did not get his blood tests back until long after that code had been completed and the man had passed away. But his potassium was over 9, and he literally went from a very mild sinus tachycardia into VFib.
There you go. So, that's a case in point. So this has really borne out in my experience as well. Another quote that I think is very instructive and we want to pay attention to is, quote, given this insensitivity of the electrocardiogram, EKG changes should not be considered necessary for the emergency treatment of severe hyperkalemia. So I do want to make a special mention as I was looking into hyperkalemia some more. I did not know this, but there is a pseudo-Brugada EKG pattern in patients with hyperkalemia, except there's no P waves and there is a markedly widened QRS. So this EKG up here is a pseudo-Brugada type 1 pattern. You can see that right bundle branch like pattern in V1 with the really sort of bulbous looking rabbit ears. Well, if you look carefully, there is no reliable P waves. So in hyper K, severe hyper K, it can actually present looking like a Brugada's. Next, we're going to go on to learning focus number 2, which is just do it. Now, what does that mean? Basically, just treat it. We're not going to go through the details of your classic treatment. Your typical treatment for hyper K is your bicarb and calcium chloride or gluconate, your Lasix, your K-Exalate, your albuterol, your dextrose, and your insulin, right? But I want to focus on the calcium and the bicarb for learning focus number 2. And there's not a whole lot that gets me out of my chair now, but hyper K is one of them. There's a handful of things that I will literally get up out of my chair and walk to the patient's bedside when I see hyper K or suspect it truly is hyper K. And that's because hyper K truly can kill you. So I want to focus on just treating the patient if you suspect hyper K. And what I mean by that specifically is just give them bicarb and calcium, okay? And the reason is because bicarb and calcium is literally life-saving. So I'm going to show you my 2 favorite calcium clips. Number 1 is, you probably recognize him. He's an alma mater, and I just love this little blurb.
Sometimes people say, well, what if it really is VTAC and I give calcium bicarb? What's the harm? What happens if somebody truly has VTAC and you give them a couple amps of bicarb? What happens to them? Nothing. If I gave everybody in this room 2 amps of IV sodium bicarb, nothing happens. It gets metabolized and it's out of your system in about 15 minutes or so. What happens if you give calcium to somebody who's not actually hyper K? What happens to them? Right? Their bones get stronger. It's great, right? There's no harm at all. There's no harm. Just try the calcium. If it's hyper K, you just saved a life. If it's not hyper K, no harm. All right?
I love that. That's number 1. Number 2 is Scott Reingard. I love this quote as well. So I think that we should just give it. If you really suspect the patient, or if you've confirmed it with the bedside potassium of whatever, extremely high potassium, just give the bicarb and calcium. It's not going to hurt the patient. I want to chat a little bit about the calcium brothers. I came up with that because there's really 2 main calciums that we have available to us. The calcium gluconate, I kind of think of it as your kind of laid back, easygoing ER doc or your brother that is not as strong, but it gets the job done, and it's just a slower pace. The calcium gluconate is about 1/3 the strength of calcium chloride. The gluconate is a sugar molecule, so it needs to be infused over 10 minutes. The effectiveness of the calcium gluconate is delayed somewhat because it has to undergo liver metabolism to release the calcium. The calcium chloride brother or colleague, he's that aggressive colleague of yours, so just in there and he's just going to get the job done right away. So calcium chloride is 3 times as strong as calcium gluconate. You can give it IV push, and the calcium is immediately available, and it is a membrane stabilizer, which, well, the calcium is the membrane stabilizer, which if it gets pushed quickly, rapidly, it will, over a period of minutes, and that's not a lot of things in medicine that will work that quickly, but in a period of minutes, it is going to stabilize the membrane and change your arrhythmia. Well, what happened to those patients? Let me give you a little follow-up. So patient number 1, now, I'll tell you, when I saw this EKG, I thought that QRS is very bizarre. Even though he's paced, that is not a normal looking paced QRS, right? So I suspected right away that it was possibly a hyperkalemia due to the fact that he just had the angiogram. So I did a quick bedside POCT, and the potassium came back 9. The creatinine was 3.6. So he had new onset renal failure with severe hyperK. And I thought that at that time, the only thing keeping this man alive was that he had a pacer in. So I went to the bedside. I had the nurse give IV bicarb and calcium. I have seen bicarb narrow the QRS. Now this is a little bit different because it's a pace rhythm, but if you look, and it's very subtle, that initially you have this very coved QRS right here, and then as we, over a period, a couple of minutes, literally about 2 or 3 minutes later, the QRS shape actually changes, and you'll see a little bit of almost like a concave shape of a normal looking QRS. And it's not convincing in the video here, but if you look at the EKG, initially you've this very bizarre, almost sine wave looking QRS after each pace beat, but after bicarb and glucose, you've got a normal looking pace QRS. So that was within minutes. And of course, that was a short-term fix. We had to get him dialyzed and all that. So that was number 1 with a potassium of 9. Patient number 2 came in, very kind of normal looking, a little bit hypotensive. We gave him bicarb and calcium also in the ED, and within minutes we started seeing P waves. And you'll see in the second EKG, he's got very definite P waves.
And his rate increased tremendously.
Right. And this is, a guy who we were thinking, well, maybe he was sotalol toxic and whatnot, but he came back with acute renal failure and hyper-K. Okay. The third one, I had very little time with her in the ER. I intubated her and asked for a bedside lab panel, and so that came back pretty quickly. Her potassium was 7.2, and we started the hyper-K treatment. We admitted her to the ICU. I followed her along. She did get an angiogram, and it was negative angio. There was no coronary artery disease. She had a temporary pacer put in the ICU, and then the family decided to send her to hospice after she was extubated, put on BiPAP.
Good cases.
So that's it. Dr. Ottney.
Well, I just have one other point.
Yep.
Remember that when you're doing the hyper-K treatment and you're pushing that insulin and glucose, not only is it a good idea, obviously, to ask for 1 hour glucose check, but make sure your nurses are doing it.
Yeah. Why? Did you have a case?
I've had a few cases of people that really were mildly hyper-K, weren't diabetics. Sugars were normal, but I wanted to treat it for the obvious reasons we've just discussed. And those are the ones that are at risk to become hypoglycemic.
Sure,
diabetic, they have a normal glucose.
Right, they don't have an elevated glucose to begin with, right.
And unbeknownst to me, I put the order in. I think it's just going to happen. And then all of a sudden they're hypoglycemic. So it's one thing when you write the order, it's another thing when it's done.
That's really a good reminder. Now, I have had so many hyper-K cases in my career, but one of the most memorable ones was here at Baywood. And I was young in my career. This is probably 20 years ago. And I'd gone upstairs to a code. And so at the time, I just remember intubating the guy after some succinylcholine, and then just kind of looking around and assessing the after procedure situation, and I'm looking up on the monitor, and I noticed that his QRS had widened, and I went, oh shoot! I gave him succinylcholine, and so I actually just gave him bicarb, and I literally watched that QRS on the monitor narrow in front of my eyes within a minute or so, and I went like, well, I caused a problem, but I knew how to fix it. Dr. Ottney, thank you so much for joining me, and thanks everybody again for watching and supporting this screencast. I really enjoyed doing it. This is my labor of love, and I hope that we'll see you again. Thanks, Dr. Ottney. Bye, everybody.
Bye-bye.